Yeah. I spoke to me, but he said anyway he will come. But okay, anyway, we will start. We will wait for 1 minute and then we will start.
Yeah.
Otherwise,
No
it
problem.
won't be.
No issues.
Yeah, it won't look good otherwise.
Good evening, Ramkrishna.
Good evening, sir. Good evening.
Good evening.
Anyway,
I have been chatting with Beg for a long time now. 10 minutes के पहले से शुरू हो गया हमारा. Yeah.
अच्छा. Okay.
He didn't let me miss Hyderabad actually.
Yeah.
Okay. So basically, it's from UG and all. From which place?
My UG was from Pratima Institute of Medical Sciences, sir, Karimnagar. And I did my DNB in Global Hospital, Lakli Kapoor, under Axon.
Acha. Okay.
Subbu sir was my HOD when I joined there.
Right.
Taken over by Dr. Geeta Nath, and I was under care of Dr. Geeta Nath and Ravi Chandraya.
Acha. Okay. Since how long you are there in Riyadh?
Now I will complete 8 years, sir, in December.
Right.
Yeah. I'm planning to move to UK. I cleared my European diploma.
Okay.
And OET also. So waiting for GMC registration.
Doing all sorts of cases, or you are confined to bariatric surgeries?
No, sir. All sorts of cases.
Acha. Okay.
Ranging from orthopedics to obstetrics and ENT.
Okay.
Plastic also. We have a big plastic center.
Right. Good to see this kind of youngsters coming to platform and all.
You people encouraged us during our PG times, and we have taken this initiative. You provided the initiative, we took the hand and we went away.
Very good. Excellent. Keep going.
Thank you, sir.
Wait, yes, Ramakrishna.
5 నిమిషాలని ఇప్పుడే మెసేజ్ పెట్టిండు 1 minute బ్యాక్.
అచ్చా. Okay.
స్టార్ట్ చేద్దామంటే చేద్దాం, ఏం ప్రాబ్లం ఏం లేదు కానీ.
We'll start, Ramkrishna. Let him join.
Okay. So good evening, one and all. Welcome to ISA Telangana webinars. This is the 8th webinar in the series of webinars for 2022. So today's topic is Principles of Bariatric Anesthesia. Speaker is Dr. Mirza Anwar Ahmed Beg from Riyadh. So I request Dr. Beg to start his lecture. Thank you.
Thank you, Dr. Ramakrishna. Good evening, one and all. Basically, I thank Dr. Aditya for inviting me for this lecture. He told me this will be a PG teaching session, and there will be some professors. So I am really proud to be presenting something in front of my professors. So if the professors feel that this is too basic, I'm sorry, sir, because Aditya told me that this will be a PG session. If I would have known that this will be presented to some senior anesthesiologists also, I will present some in the matter of presenting some studies and all. Because bariatric anesthesia these days itself is a subspecialty now, and there is in-depth research going on, and there are a lot of controversies, myths which have been deviating from the classic textbooks teaching. But for the sake of PGs, I'll stick to basic which is being mentioned in the books. To introduce myself, I am working in Sulaiman Habib Hospital. This is a leading center in the world. We do on an average 5,000 surgeries per year, bariatric surgeries per year, and in 2019 we did 6,500 bariatric surgeries, which itself is a record for a single center doing bariatric surgeries. The whole England, according to my HOD who came from England at that time, he said the whole England did not do 3,500 surgeries. So in itself was an achievement in 2019 that we crossed this mark. I see a variety between BMIs 30 to even BMIs 70s or 80s also. Maximum which I have done was 386 kilograms for a male, 386 kilograms male. And because of our changing lifestyle and immobility, which is resultant from our job. We are seeing a lot of bariatric surgeries being done. In this, a brief introduction is what is meant by obesity, various definition, various procedures which we are going to do. We are doing for bariatric patients, pre-operative evaluation, which I will go in depth, intraop management, few slides, and post-op management, few slides, because I cannot delve in depth in intraop and post-op management because this is a separate topic itself. So what is meant by obesity? Obesity is a Latin word which means fattened by eating, and bariatric means it's derived from a Greek root word called weight, and itra means treatment. So bariatric is basically weight treatment. As you know, metabolic disorders are now pandemic around the world, and obesity is the most common nutritional disorder or metabolic disorder which we can come across, apart from diabetes and hypertension. It may be multifactorial in causes. This is genetic, maybe environmental, psychological diseases. Patients, we see a lot of patients who are in depression and anxiety. They are binge eating, even though they are psychologically ill. So obesity is the second most common nutritional disorder, and second only to smoking as a preventable cause to death. Why we are going to study about obesity is because obese patients, they present a special challenge both for regional and general anesthesia. What is the incidence of obesity? When I was a student in 2011 and when I finished my PG, people used to quote American and England data, UK data, European data. I'm happy that now that we can quote Indian data also. So according to Indian data released by ICMR and Indian Bariatric Study, which was published in 2015, the prevalence rate of obesity is 11.8 to 31.3%. And central obesity is prevalent in 16.9 to 36.3% respectively. Worldwide, 7% of adult population is suffering from obesity. There is a alarmingly rising trend in school children, because parents these days, because of their busy life, they are offering them fried foods or junk foods or refined sugars, filled foods for their backpacks or schools. So the obesity is now becoming an alarming pandemic in school children. How do you quantify obesity? Basically, it is by calculating the weight and the height. There are some indices like Broca's index and body mass index, which is used to quantify the obesity. Broca's index is basically ideal body weight. According to Broca's index, ideal body weight is for females, it is height in centimeters minus 105 centimeters. For males, the ideal weight is height in centimeters minus 100. Body mass index is calculated by weight divided by height in meters square. So according to body mass index, the patients have been classified as normal weight if it is between 18 to 24, 18.5 to 25. 25 to 29.9 is overweight. Obesity class 1 starts from 30 to 31.1, and morbidly obese patients are more than 40. According to Saba, that is Society of for Bariatric Anesthesiologists, they are further classified more than 40 BMIs into super obese, super obese, and hyper obese. We rarely see, hyper obese we rarely see, but we are seeing somewhere between 39.9 to 40.5 this sort of patients commonly, and especially with insurance coming into play, morbidly obese patients with diabetes, hypertension, and other endocrine disorders, or patients with arthritis, the insurance companies, especially in Western countries and in Arabian countries, they are approving the bariatric surgeries under this BMIs. Lower than this is for cosmetic purpose. Arabians have a lot of money, so they are spending a lot. We have seen even 30, 32 BMI patients, they are coming for cosmetic purpose for bariatric surgeries. What are the different types of bariatric procedures we perform in our hospital and across the world? The most common procedure is vertical sleeve gastrectomy, followed by Roux-en-Y gastric bypass. The other procedures are laparoscopic gastric band, vertical banded gastroplasty, mini bypass. In addition to the laparoscopic procedures, there is increase in trend of using endoscopic balloon insertions as well as endoscopic gastric sleeves and gastric clippings. So we may be called for anesthetizing any of these procedures. So starting with the preoperative evaluation. Before going to preoperative evaluation, we should know what are the effects of obesity on different systems. Starting with the cardiovascular system, we know that these patients have increased blood volume and increased cardiac output, which will result in cardiomegaly. And in the long run, if there is chronic, if this patient don't lose weight, this may result in left ventricular hypertrophy, and these are candidates for potential left ventricular failure in the long run. They also, obesity is also associated with hypertension and ischemic heart disease because of ischemic heart disease is because of atherosclerotic changes as well as left ventricular strain due to increased blood volume and decreased blood supply and increased myocardial oxygen demand. Patients will have, because of atherosclerotic changes in the major vessels, there is increased chances of peripheral vascular disease. Patients are at risk of pulmonary venous thromboembolism and DVT because, first of all, the patients are immobile due to increase in weight, and there is decreased venous return. So the chances of having DVT as well as PE in obese patients is double than normal patients. There is increased risk of cerebrovascular disease in these patients. The risk is about 4 to 5% more than the normal population. These patients may present with difficult venous access. So there are different ways which I will tell in my coming slide that you can use ultrasound, or you can do a venous phlebotomy for having venous access in case of the emergency and difficult venous access. The respiratory changes, there will be decrease in compliance, both chest wall and lung. Airway resistance is increased, and there will be decrease in FRC, which will result in increased predisposition to atelectasis and increased shunt and hypoxia. Patients will have 70% increase in work of breathing and 4-fold rise in oxygen cost of breathing. So they tend to desaturate very fast. So these patients should be pre-oxygenated thoroughly, more than 3 minutes. Some patients, in some studies, more than 8 minutes. Some studies, when I remember when in 2011, me and my HOD started a study, studying the effect of having head up position and doing incentive spirometer just on table before the induction of anesthesia. And this resulted in increase in apnea time, safe apnea time. So basically, we are increasing the volume of, we are replacing the functional residual capacity, functional residual volume, whatever is there, with oxygen by increasing, by doing various maneuvers. The decrease in FRC will result in decrease in ability to tolerate periods of apnea, such as during direct laryngoscopy and tracheal intubation. Continuing with the pulmonary mechanics, there is decrease in inspiratory reserve volume, ERV, functional residual capacity, total lung capacity, and minute ventilation are reduced. But your tidal volume and residual volume will be normal. The functional residual capacity may be less than what is the closing capacity. So there will be increased chances of mismatch, ventilation perfusion mismatch. And in the long run, in chronic ventilation perfusion mismatch, there will be right to left shunting and hypoxemia. All these changes will be accentuated when you give general anesthesia to the patient, because as you know, in case of normal patients also, there will be 20% decrease. But in case of obese patients, this will increase to 50% decrease in FRC. And this is worsened by supine position and Trendelenburg position. You can offset these effects of general anesthesia by giving PEEP and reverse Trendelenburg in these patients. So you might come across this term called obstructive sleep apnea in obese patients. What is meant by obstructive sleep apnea? that it means that there is obstruction to the flow of air. And there is cessation of more than 10 seconds, and there is frequent apnea and hypopnea in these patients. What is the incidence? There has been a study which said that over 5% of patients who are obese, they are affected with obstructive sleep apnea. So 95% of patients, they don't have, but only 5% of patients have sleep apnea, and you have to be, cautious in these patients. What are the risk factors which predict having obstructive sleep apnea in this patient? If you see a patient with short muscular neck and large collar size, that is more than 40 centimeters circumference of neck, pharyngeal abnormalities, and alcohol consumption, which is more during evening, these patients are at high risk of having obstructive sleep apnea. What happens when there is the patient will have pharyngeal abnormalities? There is passive collapse of pharyngeal airway. There is cessation. There is obstruction to the flow of air especially during deeper planes of sleep. So when the patient is having absence of flow, there is hypercapnia, which is a respiratory stimulant, and hypoxemia also to a certain degree. This hypercapnia, which is a respiratory stimulant, will result in increased waking up of the patient and breathing again. So there will be a cycle of apnea and hypopnea in this patient. So as a result, there will be disturbed sleep in this patient, hypoxia, hypercarbia, and patient will get tired easily, increased daytime somnolence, and in school-going children, it is associated with poor performance in the school. There is another term known as obesity hypoventilation syndrome. So there is obstructive sleep apnea at one point, and if this continues, there will be, as I said, hypercarbia is a respiratory stimulant. But once this becomes a chronic process, there is loss of sensitivity to hypercarbia. There will be combination of hypoxia. There will be cardiopulmonary and polycythemia, respiratory acidosis, pulmonary hypertension, and right ventricular failure. This complete clinical picture of right ventricular failure associated with obesity is known as obesity hypoventilation syndrome or Pickwick syndrome. So OSA and obesity hypoventilation syndrome, they are diagnosed by polysomnography and ABGs. Polysomnography classification is mild, moderate, and severe. 5 to 15 is mild OSA, apnea hypopnea index. 15 to 30 is moderate, and severe OSA is more than 30. What are the gastrointestinal changes which are associated with obese patients? There is increased acidity and volume of gastric contents. Why there is increased volume of gastric contents? Because of hypercarbia, there is increased proton availability. Increased proton availability is a stimulant for increased secretion of gastric juice and pancreatic juice, biliary juice. Also, there is increased acidity due to protons. There is, because of deposition of excess fat in the abdomen, there is increased intra-abdominal pressure, which will press on the stomach, and the transgastric pressure is increased. There will be decreased lower esophageal sphincter. So the lower esophageal sphincter pressure is less than what is there in the stomach. And because of this, these patients are at high risk of regurgitation and aspiration. So you have to intubate this patient in a slight head-up position, and there is one school of thought that you have to extubate this patient while the patient is awake. But this is being contradicted by present studies with the POCUS. They say that if you do a point of care ultrasound, you can see the gastric contents and decide whether to do a deep extubation or awake extubation. Coming to the changes in the liver, because of fat deposition, there will be fatty liver and cirrhosis. Increased chances of cirrhosis in the liver. Endocrine system, it is associated with glucose intolerance and diabetes mellitus. As we all know that obese patients are at high risk of diabetes and glucose intolerance. Hypercholesterolemia, hypothyroidism, and Cushing syndrome. These are rather the cause of obesity rather than the effect of obesity. PCODs are effect of obesity. Metabolic syndrome, which comprises of diabetes, hypertension, and hypercholesterolemia, is a consequence of obesity. What are the other changes? Patients may suffer from gout, osteoarthritis of weight-bearing joints. They may have back pain and abdominal hernia due to lax abdominal wall muscles, breast and endometrial malignancies. Apart from the physiological changes, you need to consider what are the pharmacokinetic changes which can occur with obesity. There is increased lipid compartment size, and decrease in water compartment. So the volume of distribution of drugs is altered. There is also decrease in, because of increased fat, there is decrease in protein and altered protein binding. And because of this, as the clearance of the drug is dependent upon volume of distribution, the clearance of the affected. So while dosing the drugs, you need to calculate either the ideal body weight or lean body weight. There are some drugs, as you can see in this slide, like propofol as an bolus or intermediate propofol and succinylcholine as they are given bolus only. They are based on total body weight. But if you are giving as an infusion, any drug as an infusion, you have to be with total body weight. Morphine, opioids, and muscle relaxant, they are based on lean body weight. So once you have known that what are the changes associated with obesity clinically,
There's no voice, excuse me.
Internet problem from speaker.
hello? Hello?
Yes, sir. Yes, sir.
I think I've lost connections actually at that time.
You can go ahead now. You can go ahead.
I can go ahead, sir.
Yes, yes.
Okay. Just a moment, sir. So I don't know where I was. I'll check. I'll see. Can I share my screen?
You are calculating the drugs. You are at the level of calculation of drugs on based on lean body weight or
Lean body. Yeah.
Yeah.
So this slide I was. I'll do full mode. So once you have done the assessment for once you know that there are some changes with the physiological as well as pharmacological changes, and the patient comes to you, take a detailed history, do a physical examination looking for various changes, various system changes, and especially look out for OSA, which is associated with high risk during in the post-operative period for respiratory complications. put a hand on the calf to check for tenderness and for DVT. Check for the prior anesthetic records so that you know whether this patient had any difficult airway or venous access, history of difficult airway, venous access, and previous surgeries if there is any difficulty in management, intraop management, or anaphylaxis or allergic history. Once you have done the assessment, you will know whether this patient is for ICU or post-surgical, associated with post-surgical outcomes. So, the most common or feared aspect of anesthetizing patients with obesity for UGs especially, they think that this patient may have morbid difficult airway. Whenever they see a patient with obese, they say, oh, this patient may be a difficult airway. But a study in 2019 said that out of the 45,000 patients which they anesthetized, only 1,893, that is 4%, were difficult intubation patients. To make you more, calm, I have anesthetized. We have been anesthetizing around since 2015, maybe more than 20,000 cases. In these 20,000 cases, only 3 patients I remember as of now, because we do. I'm a core member of bariatric team. Only 3 patients required awake fiber optic intubation. Only 6 or 8 patients had unanticipated difficult intubation, which was overcome by using a video laryngoscope. So when you see an obese patient, don't get scared. Just prepare your difficult airway cart anyway, as you prepare for any other case. Okay. So what are the best predictors of difficult airway in these patients? Only 2. There have been a lot of variables which have been studied, like Mallampatti, weight, stop bang, OSA, age, and all. Only 2 variables which have been shown to more effective is BMI and neck circumference, which are significant associated with neck circumference is significantly associated with difficult intubation and difficult ventilation. So your basic tests like neck circumference, Mallampatti, and limited mandibular protrusion, they are more important risk factors than poor dentation and OSA, according to a study which was published in Italy. So for the PGs, your main assessment in the exam, if you have a obese patients, your main assessment will be on airway. How do you assess the airway? So I know maybe this is the PG1 question, how do you assess the airway? But I will show here some slides which will help you recollect how do you assess. So this is Mallampatti scoring, class 1, class 2, class 3, and class 4. Class 3 and 4 are associated with difficult airway. Class 1, if you see both the pillars, soft pillars, and uvula, and on protrusion of tongue, it is class 1. If you see only soft palate and uvula process visible, there is class 2. Only soft palate and base of uvula visible, it is class 3, and hard palate only visible is severe difficulty. Then higher mental distance, that is Bartle's test. If it is from the tip of the thyroid cartilage till the tip of the mandible, the distance is measured. If it is more than 6.5 centimeters, no problem of intubation. But it is less than 6 centimeters, this is a predictor of difficult laryngoscopy and intubation. Other test is Saba's test, which is sternomental distance or theromental distance, which you commonly say. The distance is measured from the tip of the maryverium sternum to the tip of the mandible. If it is less than 12.5 centimeters, this is a single best predictor of difficult laryngoscopy. This has high sensitivity and high specificity. So sternomental distance or Sava's test, this has high sensitivity and high sensitivity for predicting difficult intubation and ventilation. Interincisor gap, you ask the patient to put their own 3 fingers, not your finger, their own 3 fingers. If they can put 3 fingers normally, no problem with the intubation. If less than 2 centimeters, difficult LMA insertion. Less than 3 centimeters, difficult laryngoscopy. So it should be at least 3 centimeters. Then warning sign of Delica. What is this? You ask the patient, you put your index finger below the chin, and another index finger below the occipital prominence, and ask the patient to slightly extend the neck on the head. So if this finger, which is at the tip of the mandible, is higher at the higher level of the finger, which is in the occipital protuberance, there will be no difficulty in intubation. But if it is at the same level or at the lower level, the tip finger, index finger at the chin, then there is an increased difficulty can be predicted. So if you correlate all these airway, difficult airway tests like TMJ distance, mouth opening, and Malampati, so basically you have to correlate, club this together and predict, take a difficult airway score. This is a stop bank questionnaire, especially for predicting the OSA. You ask the patient whether the patient is having snoring, tiredness. Patient's attendants have to be asked for whether you have observed apnea. A patient is suffering from high blood pressure. So you mark these patients, and each these are eight variables, and each is valued as 1. So if it is 0 to 2, low risk of obstructive sleep apnea, 3 to 4 intermediate risk, and more than 5 is high risk for obstructive sleep apnea and difficult airway prediction. Once you know that this patient is, you have anticipated this patient will go for, will be a difficult airway, just revise your difficult airway intubation guidelines from ASA and ISA. Both societies have very beautiful flow charts. You can keep them in your mind or put in your theater. Once you have evaluated the patient clinically, you need to go for laboratory test. One of the basic tests which is mandatory is ECG, because these patients may be associated with silent MIs, especially in diabetes. The LV strain, which is commonly, which is easily seen in ECG, or left ventricular hypertrophy, any axis deviation, or any arrhythmias can be picked up in ECG. 2D echo only if this patient is having any breathing difficulty or limited exercise capability. And the most useful test for you having cardiopulmonary exercise testing, non-invasive one, is 6-minute walk test. You ask the patient to walk 6 minutes in a circle rather than in a straight line. And if he is able to complete a specific distance, then the exercise capability is okay. But if he is not able to complete, then the exercise capability is less, and it is a predictor of post-op pulmonary complications. So baseline ABG, this will help in evaluating the carbon dioxide retention and provides guidelines for perioperative oxygen administration, whether you have to give more oxygen or less oxygen, and also a predictor for weaning from post-operative ventilation. Basic screening for diabetes, fasting blood sugar and random blood sugar, HbA1c, which shows 3 months blood glucose control, lipid profile, and PFT if needed, if the patient is complaining of severe restrictive breathing, breathing disorders. In our practice, in our center, we hardly do PFTs or 2D echo for patients who are young. Only patients who are a history of smoking, COPD, and known case of respiratory disorders are subjected to PFT. We are not doing routinely PFTs or polysomnography. This slide only is helping the PGs to mention in the exam. Okay. What are the different risk score? Commonest risk score which you are using is revised cardiac risk index, that is LEAS. You have to mention that, and then P-POSSUM scoring, which has different variables, 8 variables, that is age, cardiac signs, chest radiography, systolic BP, Glasgow Coma Scale, white cell count, urea and sodium. This will help in P-POSSUM will help in predicting post-operative morbidity and the need for post-operative ICU and ventilation. The surgeons themselves, they risk the patient, which is obesity surgery mortality risk score, which is based on 5 variables. So they will calculate the risk score. Once you have done the clinical assessment, laboratory assessment, now you have decided that you will do the bariatric surgery. So it is a multidisciplinary approach. You need to consult multiple specialties, nutritionist, who will decide about post-op nutrition, surgeon, and a cardiologist if there is need to optimize the patient cardiologically, cardiovascular wise, pulmonologist if the patient needs to be optimized on her CPAP if the patient is using CPAP before, or post-operative respiratory support. And then you have to do risk scoring. You have to assess the availability of resources with you. That is, whether you have any advanced difficult airway access instruments with you, that is cricothyrotomy needle, your difficult fiber optic, awake fiber optic, if you want to do a fiber optic, video laryngoscopes, ultrasound to get venous access or arterial access. And then you have to decide whether you are able to implement this plan. So an anesthetist has to do multiple tasks. One has to do physical and mental exercise a lot. You have to draw medicines according to the body weight. You have to prepare the equipment, and then you have to guide the transfer of patient from bed to OR table and OR table to the recovery bed. Then you should be able to effectively coordinate with the OR staff for better management of this patient, ranging from the anesthesia technician to the nurse, OR nurse, for positioning, for drawing drugs, and getting in case of emergency help. And the most important thing which we are lacking in India, I feel, is documentation. You need to document every step of yours, right from the pre-op anesthesia, intra-op anesthesia, and post-op anesthesia, with rising, increase in medical legal cases. So once you have decided to make a bariatric surgery for this patient, the surgeons themselves, they will, in our hospital, actually, we don't follow. The patient comes today and their surgery will be tomorrow. So we have seen across the BMIs, various BMIs also, the patient, if they have money, they're asked to sleep tomorrow for the surgery. But in some centers, they are following strictly this 1 week, 2 weeks, 3 week diets, especially depending upon the BMIs. This helps in shrinking the liver. This is called liver diet, or this helps in shrinking the liver to improve the access, especially in patients with huge BMIs. So you have made the plan. You have made the patient fast, or given the patient's instructions, made the given the patient education about this. You have to be prepared for all the crisis if it is to be happening. So don't run, don't panic. You know your BLS, you know your ACLS. Okay, keep calm, and you will be able to manage this situation if you anesthetize this patient. So what are the pre-op meds we need to give? So sedatives. One school of thoughts is you should not give sedatives. This may result in precipitating respiratory depression. But IV sedation just before sleeping to help in reducing in the holding area is not a deterrent. You can give anxiolysis with short-acting drugs like lorazepam and midazolam. PPIs have to be given to reduce the acidity of the situation, gastric secretions. Antisyllagogue if fiber optic intubation is planned, but it is not given routinely. Dexamethasone 8 milligrams preoperatively helps in not only PONV, which has been shown to be, there are studies which have shown that dexamethasone reduces the incidence of PONV, but also it helps in multimodal analgesia. Pre-analgesia with oral paracetamol 1 gram before the surgery and oral COX-2 inhibitors. Some surgeons, they don't like, in my hospital, they don't like, the lap sleeves and even for bypass, because they say that there increases bleeding, but this is not proven from other center studies. This is just their mindset. DVT prophylaxis, 5,000 subcutaneous before the surgery, 1 hour or 2 hours prior to the surgery. If it is to be by Clexane, it has to be 12 hours prior to the surgery. IV antibiotics 1 hour before the surgery as per the WHO. What is the intraoperative management in these patients? So just a small slide because we are running out of time. So you have to plan what are the challenges intraoperatively you will face is airway management. As I told you that you have to prepare your airway cart. Difficult airway cart should be prepared with plan A, B, C, D racks. A should be containing different size tubes and blades. B should be containing LMAs. C should be containing your difficult, intubating LMA and your cricothyrotomy or tracheostomy needles. Then positioning. In this slide, I will come back to the previous slide later. In this slide, I am showing that we have to be very careful when the patient is being transferred from the holding area to the OR bed. You have to log roll the patient, especially for very obese patient with BMI more than 60 or 70, try to log roll them. This will help in preventing fall. Put pillows under the chest. One special position called for bariatric surgery is ramp position, where you put pillows below the chest and below the neck, so that the level of lower tragus of the ear is at the level of sternum. This helps in good reoxygenation and help for intubation also. This slide is better, especially if you are after the induction of the patient. This is the correct position, especially this slide B, which shows 35 degree flexion of the neck on chest and 15 degrees flexion of the face. So this will be resulting in laryngoscopic axis, pharyngeal axis, and oropharyngeal axis in a plane. So this is the best position for intubation. So other thing is the table should be able to hold the weight of the patient. Typically OR tables, which in India, or I don't know whether things have improved actually. I don't know. I'm not anesthetizing patients in India since 10 years, so I don't know. But it used to be less than 150 kgs or 200 kgs max, which we use. But our tables, they can handle about 300 kilos, and there are extensions available for if there is more than 70 kgs and patient is more fat. So we have table extensions available. Monitoring ECG and sphygmomanometer, ABP monitor, non-invasive blood pressure monitor with the cuffs more than 20% diameter, greater than the diameter of the arm. And then if needed, we can use invasive blood pressure monitoring. Choice of anesthetic techniques and anesthetic agents, you have to consider various comorbidities while we are using the anesthetic techniques and anesthetic agents. Pain control, fluid management. Some school of thought say that it has to be a liberal fluid so that it helps in POMV as well as in there is length of stay. Some studies have shown that liberal fluid strategy has shown that more than 7 ml per kg has shown that there is decreased length of stay and decrease in POMV. But there are some school of thought that even less than 5 ml per kg is better for these patients, restricting them, resulting in less anastomotic leak actually. And we follow less than 5 ml per kg. Actually, in our center, we do surgeries within 30 minutes or 45 minutes. The surgery is completed. So we hardly get any time to supplement this fluid. It is done either pre-op or post-op. Temperature management is also an important aspect of managing these patients. So once you have anesthetized and you are finding it difficult to do an intubation, for the PGs, this is one maneuver you need to remember. This is called Burr maneuver. What is Burr? This is backward, upward, rightward pressure. Backward pressure on the thyroid cartilage so as to about the larynx against the body of cervical vertebrae. Upward pressure, the thyroid cartilage is moved upward 2 centimeters until mild resistance is met. Rightward laterally to approximately 0.5 to 2 centimeters, and pressure is there. This will improve the visualization of the larynx, at least by 1 grade. If it is Cormack-Lehen 1 or 3 or 4, it will be 3 or 2. So venous access, we have ultrasound in our department, so it helps in getting access in difficult venous patients, and as well as we have venulite by which we can see the veins. So what is the intraop management? We have to use insoluble anesthetic agents resistant to metabolism like desflurane and sevoflurane without lipid deposition. Okay, and patients have to be used the rocuronium or succinylcholine, which are easily reversible. Those muscle relaxant has to be used. There is controversy regarding use of N2O, but for exam purpose, you can mention N2O. But in clinical purpose, we are not using N2O because patients with pulmonary, especially with patients with pulmonary hypertension and gastric bypass procedures, because it will result in this gaseous distension, and it has shown to be associated with gastric leaks. Alternative to remifentanil, intraop analgesia is with remifentanil or high dose short-acting opioids. Alternative to remifentanil is dexmedetomidine. With dexmed, the advantage is no respiratory depression, analgesic, and rapid arousability. But disadvantage is bradycardia and hypotension. During the intubation, you have to think, especially for textbook teaching, for obesity patients, the PGs have to mention in exam that we have to do rapid sequence intubation. But there are recent in 2013, there have been a study which was published in the European Journal of Anesthesia. It has said that patients with obesity need not routinely undergo rapid sequence anesthetic induction unless and until it is a very difficult airway. Because RSI has its own risks. That is, there is a risk of awareness under an overdosing of drugs, impaired visualization during laryngoscopy and hypoxia. And these risks are greater than potential risk of aspiration. So they said that unless there is patient has having, very difficult airway or the patient is having full stomach, then only you have to do RSI. If not, no routine RSI is to be done. So you can see in this picture what are the different positions. This is surgeon standing in the middle and with the legs spread. One type of procedure. The other position is the surgeon standing on the side of the patient on the right side and the screen on the left side. And the patient is made to made the reverse tendon bulb. Okay, so you have to take care about positioning, prevent nerve injury, cushioning of feet and pressure point. Especially with this position, the patient is completely pushing the feet and the legs are completely pressing down on the support. So you have to cushion them well. Take care of pressure point, especially the ulnar nerve and the axilla. And as you monitor, you have to understand that there are changes with the position during the laparoscopy and inflation of the gas, abdominal insufflation. So with the induction, there will be decrease in SVR, decrease in MAP, decrease in cardiac output. What are the other hemodynamic changes are with abdominal insufflation? You will be, there is decrease in MAP, increase in systemic vascular resistance, decrease in cardiac output and cardiac index. With abdominal desufflation, sudden deflation, what happens is decrease in SVR, decrease in MAP, and increase in cardiac output. When the patient recovers from anesthesia, there will be increase in heart rate, increase in MAP, increase in SVR, especially when the patient is light and having pain. So you have to keep these hemodynamic changes when anesthetizing this patient. What are the different modes of intraoperative analgesia? Multimodal approach. We do incremental doses of short-acting opioids, and at the end of the surgery, we give morphine to this patient or pethidine. Ketamine. If you are thinking of doing completely opioid-free, you can use paracetamol, dexmedetomidine, and ketamine. This is an excellent analgesic and underutilized analgesic. So you can do opioid-free bariatric anesthesia with ketamine, dexmedetomidine. Dexmedetomidine is given as initial bolus as 1 microgram per kg 10 minutes prior to induction and 0.25 microgram to 0.3 microgram per kg per hour intraop till the patient is awake. Dexamethasone 8 milligrams IV is also shown to be an effective alternative in the multimodal armamentarium of multimodal analgesia. I give usually if the surgeon requires and the patient is VIP, if they suggest, we give 4-point ultrasound guided tab lock. That is to rectus sheath. With the most painful part is the rectus sheath. So I give bilateral rectus sheath 15 ml and 15 ml in the subcostal region. The surgeon himself can, after putting the port in very obese patients, if you cannot see properly in the ultrasound, the surgeon themselves can do lap assisted block. This is comparable to ultrasound guided block. Pre-operatively, when we started, when my HOD came from, current HOD came from England, we started doing all patients with OSA and high-risk patients, pre-operative erector spinae block bilaterally, and they gave excellent result. We didn't had to use any opioids post-op, only paracetamol and tramadol rescue. NSAIDs, there is still controversy, especially in bypass surgery. As I said, they say that it increases chances of bleeding. Extubation criteria for the PGs, you have to remember that the patient has to be awakened, fully awake and alert with head lift greater than 5 seconds. The patient should be normothermic, hemodynamic stable. And if you are monitoring train of 4, check that the patient has 0.9 reversal on ratio of train of 4. Then full reversal of neuromuscular blocking agents. You can use prior to the availability of Bridian, that is Sugamadex in our hospital, we were using double the strength of neostigmine and double the strength of atropine, so to ensure complete reversal. But now we have availability of Sugamadex with us, so we are routinely using Sugamadex. So if you are doing an ABG, especially in super obese patients, if you want to guide the ABG for your extubation, pH should be 7.35 and PCO2 should be less than 50. PO2 should be more than 80 millimeters of Hg. And negative inspiratory force should be more than 20 to 30 centimeters. Volume, vital capacity should be more than 10 ml per kg, and acceptable pain control. In post-operative period, the patients have to be nursed in a sit-up position, do incentives parameter. You have to monitor the oxygen and ETCO2. We have now a special monitor with the in the PACU that we are continuously monitoring the ETCO2 in the oxygen mask. Then adequate analgesia to allow deep breathing and coughing, and continue the DVT prophylaxis in the ward. PONV prophylaxis with granisetron. We have granisetron, tonacitron, and dexamethasone. If you feel that if your pre-op assessment has shown that the patient has high risk for having post-operative respiratory complication, just go with CPAP and call the ICU for further care. Post-operative analgesia, there is no clear data that one analgesic is superior to other. You can give multimodal perioperative analgesia with local site infiltration and NSAID, and you can also use PCA. In case where the patient needs to be avoided, the patients with OSA, you can use dexmedetomidine or clonidine and magnesium sulfate. Post-operative complication, the most common post-operative complications associated are respiratory depression due to use of opioids or muscle relaxant. Early ventilatory failure, which will result in reintubation, positional ventilatory collapse, because of the position, supine position, sometimes there will be positional ventilatory collapse. So there will be, and because of pain, inadequate respiratory excursions, the patients will have oxygen retention, oxygen hypoxemia, and carbon dioxide retention. Hemodynamic instability, hypotension is the most common is seen in post-operative period, because of decreased fluid use and various opioids, as well as various mix, which what we are doing in anesthesia. Post-operative nausea, vomiting. The long-term complications are anastomotic leak and wound infections. Especially wound infection is common in obese patients. They are high risk of wound infection. So the take-home message is that the anesthetic care of obese patients is not difficult if you have self-confidence, build some confidence in yourself. You know your BSLS, you know your ACLS, you know how to intubate, you know how to do CPR. So no need to worry. You can sail through it. learn to communicate with multiple team members, and especially the patient itself. If you explain the patient that, okay, I'm going to do such and such things on yourself, you'll be given such and such analgesic in your post-operative period, you need to do chest physiotherapy like this, then the patient will definitely cooperate in the post-operative period with you. Make yourself aware and comfortable with the limited resources. If you are available, if you are working in a limited resource center, you make yourself comfortable with that. But even if you are working in such centers, don't compromise on safety, yours and patients. Document well what you have seen, done, and intend to do. Brush up your clinical skills, that is pre, intra, and post-op. Anytime reading is not a bad idea. Thank you.
Right. So, yes, thank you, Dr. Anwar. That was a very concise and simplified way. So
it was for PGs basically. I am sorry. Any senior anesthetist?
No, that's good. The basic target here is for the postgraduates only. So before we move on to my questions, there is one question in the chat box.
There are a few questions I can see. Then
yes,
can I answer them one by one?
Yes, you can answer them one by one.
So the first question is your hospital running any fellowship? They are not running any fellowship in our hospital because internally, I will tell you here, between us, we are not doing anesthesia there. We are doing just business. We are not doing surgeries there. It's like, the one surgeon operating in 3 rooms, he will be here, there, here, there. And it's like one patient is pushed, the patient, once the patient is out of anesthesia, the patient has to be within 2 minutes, next patient has to be anesthetized. So we are doing like business here, not anesthesia. So I'm sorry that we don't want to teach juniors like this. But actually we have a very good bulk, very huge bulk. And if we do studies and if we do training, it will be a very nice center actually. Right. Are you giving decaf in diabetics also? Decaf.
What's that?
Dexamethasone, sorry.
Dexamethasone, yeah. 8 milligrams of dexamethasone is not problematic. The studies have shown that 8 milligrams of dexamethasone in diabetics also is not a problem. We are giving routinely 8 milligrams.
Okay.
So
one more question.
Which approach in erector spinae block you practice before induction? This is before induction, because after induction it will be very difficult for patient to be positioned for erector spinae. So we, as I said, once the surgeon says that anesthetize next patient. So what I used to do with my HOD is I used to stay in the room, or he used to stay in my room, and I used to give Presidex. I used to start paracetamol and Presidex in the holding area and do the block there.
Right. So those are the questions that are available. Can I now request Dr. Deepa Singh sir to add few points? Hello.
Hello.
Yes, sir.
Yeah, good evening, Aditya.
Good evening, sir.
Yeah, we have very little experience with the bariatric surgery. It is done only in few centers here.
Sir.
Probably this was a very nice lecture by Dr. Baig.
Yeah, thank you, sir.
Actually, what is the protocols for post-op ambulation? How early?
Sir, we are within 1.5 hour, 1 to 1.5 hour, because with ours is a very high turnout unit. So within 1 hour, the patient is sent to the recovery, from the recovery to the room. And from the room, the patient is being started to walk within 2 hours.
Okay, that's very nice.
Actually, we are doing what is known as daycare bariatric surgery. The patient is the patient is operated today, and tomorrow morning he is discharged. So it's almost like daycare bariatric surgery.
Okay.
Dr. Aditya.
Sir, yes, sir.
Yeah. Let me add some few points. Mirza, it's a very good topic. I know it's purely you are prepared for PG, maybe time constraint, but still this particular program, not only PGs, most of the consultants are also joining regularly. So
what was said to me was it is for PG teaching. So
no. Basically,
in in the beginning of my talk, I said if it is for senior consultants, I have to present you because there are a lot of controversies, even for, like, for example,
it's all right. No, basically this program started for PGs only, but most of the faculty members also join, interesting to listen any important topic and all. But here, even for PGs also, there are some few points I would like to add. Number one is, since obesity is an inflammatory disease, inflammatory markers are also being done preoperatively. There's a for the risk assessment for post-operative complication, IL-6 particularly, that is the one. Of course, this is not for PG level, but that's a point to be added. But next important thing, what I, even for PGs also, the problem starts as soon as you induce the patient. As soon as you induce the patient, so once the patient being induced, so we know that totally the airway collapses, the mediastinal weight and all, VQ mismatch starts. So what is the, I think, again, I am saying it's not that you missed and all, you just constrain yourself, limited yourself, not going to detail. But at the time of induction, as soon as you induce the patient, the VQ mismatch starts because of the alveolar collapses and all, there's a desaturate rapidly. So most of the articles, most of the studies, what we have seen and what we have come across, whatever the limited exposure to bariatric, I mean, not bariatric, but overweight or obese patients, while ventilating a patient after giving relaxant, it's better to ventilate the patient with ventilator with a PEEP on, not with a manual ventilation. The better, so alveoli will be opened up because of the PEEP is applied at the time. As soon as you induce the patient, once the patient is knocked down, ventilating the patient, start in a ventilator support instead of manual ventilation. That's the one. And second, during maintenance, invariably the ventilatory settings is a pressure control, volume control. Of course, there are no data as such which is a better one. But one thing is ARM to be applied. ARM, alveolar recruitment maneuver, are to be applied every 40 minutes. That is the one. What is your experience? What is that you are doing for this? And again, because alveoli again after some time, VQ mismatch, alveolar collapses. This is an issue. Of course, your surgery being within half an hour, 40 minutes, that may not be a big issue. But any surgery prolonged beyond 40 minutes, 45 minutes, 1 hour, since laparoscopic.
Actually, sir, I'm working with people of different nationalities. So
yeah,
the Arabians, like Egyptians and Jordanians, they tend to use very less PEEP and airway recruitment measures. But if you see the Europeans and the Saudi themselves, Saudis who have trained in Canada, especially their government provides for their learning in Canada. So these people, they are more towards using ARM, recruitment maneuvers, as well as PEEP and all during the surgery. And they better avoid nitrous oxide. Again, this is a controversy whether to use nitrous oxide or not. Yeah. That's what I said. There are a lot of myths and a lot of facts which are being, which we during this 5 years of my stint here. When I worked in Global Axon, I was doing bariatric surgery with Dr. Raya and Dr. Subbu. The approach was totally different. And when I came here and started doing bariatrics, the approach is totally different.
So didn't you ever come across any desaturation with the regular ventilatory settings and all?
No, there are at times we have come across, especially in very hyper obese, like more than BMI. We have seen desaturations, especially after. But there are multiple factors for this. This may be in this limited 40 minutes. You cannot know whether this is due to any allergic reaction. This is due to disconnection, or this is due to any mismatch, or sometimes in patients, especially hyper obese patients, they have hiatal hernia. When the surgeon tries to do hiatal hernia repair, there is invariably some amount of air going into the mediastinum. So there will be some amount of desaturation at that time because of pneumomediastinum.
And what is your experience about at the time of laryngoscopy till the intubation, oxygen insufflation through the nasal catheter to support to prevent desaturation?
Sir, the recent we are not doing it, but the recent studies, especially in Europe and UK, they have shown that rapid insufflation through nasal cannula, Thrive is very beneficial, especially in patients with obese patients, which can prolong the intubation time, safe apnea period.
Right.
And I personally recommend, if you are doing it, and if you have time, if you don't have any surgeon who is sitting at your head saying, banging on your head that go fast, you can try this.
And how do you extubate? This commonly recommended almost like a sitting position to be extubated.
We do sitting extubation, sir. I shift the patient on the bed, make the bed prior to the extubation, make the bed around 30 to 40 degrees head up, and log roll the patient, and I extubate on the bed rather than on the OR table.
Right. Good, excellent. These are the few points just I wanted to have. Okay, nice. Nice, Mirza. Nice.
Thank you,
sir. Any more doubts in the audience? Okay, now before
I basically did not delve into intraop management and fluid management also. Fluid management is difficult. There are a lot of changes.
That's okay, Mr. Now two things from my side. Now, as you said, yes, Thrive technology is one what we can use, but in Indian setup, as you know, there are a lot of still areas where there is a lot of deficiencies. So what we usually try to do here is we put them on NIV, any obese patient, prior to intubation. That is one thing. Now, what are the indications?
That's what I said, Aditya.
What is the indication and contraindication of putting a patient on NIV post-op in such cases?
So first of all, regarding the NIV, as I said, you know Dr. Mohan, right? You know Dr. Mohan in Global. Dr. Mohan and me and Dr. Ravi, we did one study, as I said, pre-oxygenation in head-up position as well as using incentive spirometry. When we were doing this study, we searched the literature and found out that incentive spirometer is better than doing NIV, because NIV is there is a lot of air thrown into the stomach. So there are chances that of regurgitation and aspirations, but incentive spirometer is better than NIV. This is one aspect of your question. Second is pre and post-op NIV. Post-op NIV, our surgeons are very strict. Only for patients with OSA, they allow us for post-op NIV. If not, no. And especially contraindicated in bypass surgery, Roux-en-Y bypass and switch surgery, duodenal switch.
Okay. That's good enough.
Next question which I come across here is, which arrhythmias you have faced most of? The ventricular premature beats and AF.
Okay.
And these are harmless arrhythmias. They are harmless, which can be easily reversed by giving oxygen, taking care of your hypercarbia and all.
Okay, that's good. Any further doubts? Ramakrishna sir?
Is he there?
Ramakrishna sir, he was there, sir. I'll see. Okay. So if there is no other doubts, one thing I would like to tell all the postgraduates, as Dr. Anwar was telling. So there is one saying, Ambani says money is not important to lead a life. That is only after he got the money. So as he said, once you have got all the confidence of doing all the basics right, you can take a case. But again, preparedness is always never a substitute. Make sure you are well prepared. Do not hesitate to call for help. There is no role of heroics in any part of the globe. Save patient, save yourself is more important. And make sure that in case of difficulty, as I said, documentation, calling for help, and regularly training yourself are very important aspects that everyone needs to focus. So with this thing, I thank Dr. Anwar for a very beautiful and concise lecture and his insights into the bariatric anesthesia. I thank all the professors for giving their wise words and mentoring us through all this thing and supporting us in doing this ISA CMEs or lectures which actually is helping out all the consultants as well as the postgraduates to refine their practice in a better way. I thank one and all. With the permission of the professor, if there is